So good afternoon, everyone. First talk will be by Dr. Sunil. Dr. Sunil is a prolific veterinary surgeon from Davangere. He's the chief instructor of this course. Dr. Sunil, you can start. Yeah.
Thanks, Sachin. So I'll be talking to you basically regarding the imaging and what are the things which you can image and the utility of different imaging techniques. So imaging in myopia, in eye myopia especially, it's a challenging scenario because you tend to get an optics related aberrations. Focusing ability is a difficult thing, especially in very high myopes. Morphological alterations in myopic fundus and optic nerve makes the imaging difficult in myopes. As we know that conventional photography is challenging, especially when you're associated with wide staphylomas and peripheral lesions, you may miss it. What do we mean by ultra wide field is you basically tend to image beyond the vertex veins in all the 4 quadrants, and it covers up to 200 degrees, but the only disadvantage is it doesn't provide the 3D imaging system. So basically this ultra wide helps in identification of many lesions, classifications of staphylomas, progression of chorioretinal lesions, and the entire extent of the cephaloma and peripheral retinal degeneration can be imagined. If you look at the monitoring of degeneration progression in myopia, it starts with a tessellated fundus and ultimately ends up with a end stage myopic chorioretinal atrophy, and there is a gradual choroidal thinning also. The thing is, anything which is the initial, if you leave apart the first picture, the rest of 3 fits into the something called as pathological myopia. The first one probably could be call it as an eye myopia. Another wide field imaging utility is the use of ultra wide fluorescence, autofluorescence. It can be helpful in cases of staphyloma. You tend to see some pigmentary alterations at the edge of the staphyloma and other things. Even the lattices, like in second picture here, you can image a non-pigmented lattice and it can be very well shows as an hypo, and the radial tracts. And many peripheral lesions can be picked up on autofluorescence also. This picture clearly shows what is the difference between a conventional and a wide field photography. If you done a conventional photography, you would have picked up only these myopic atrophic lesions on an autofluorescence. But if you look at the ultra wide field, if you take, you can see a multiple hypofluorescence spots. This is a coexisting of multifocal choroiditis with a pathological myopia. So sometimes a wide angle can pick up a varied diagnostic lesions than if you do a conventional photography or conventional autofluorescence. Posterior staphyloma, as we know, present in most of the 90% of pathological staphylomas and can be associated with myopic maculopathy. What are the morphological hallmarks of a staphyloma and ultra wide field OCT? You tend to see a thinning of choroid from periphery toward the staphyloma edges. There is a gradual re-thickening of the choroid in the direction towards the posterior pole, along with posterior displacement of the sclera in the staphylomatous area. Even you can get a 3-dimensional image also to get the see for the staphyloma, the exact location of the staphyloma can be done. And there is a gradual thickening and inward protrusion of the sclera as shown by these arrowheads at the staphyloma edge. The studies have shown that if you use an ultra wide field, then the conventional OCT, what it picks up the pathology in 69%. If you do use an ultra wide field, another 15 to 20% of the lesions you can pick up with the ultra wide field OCT. The presence of staphyloma is irrespective of axial length. You may tend to see a staphylomas. This is a multicolored imaging, the pseudo color, autofluorescence, the red free images, and this is a 3D MRI showing the staphylomatous changes. This is a depigmentation at the edge of the staphyloma. This is an hypofluorescence at the edge of the staphyloma due to the pigmentary alterations. And this is a red free image which is showing an hyperreflectance. And this is a 3D MRI showing an outpoaching. Sometimes the subtle staphylomas, which can be difficult to be picked on in 3D MRI as well as color photograph, can be picked on ultra wide field OCT. So you should use a multimodal imaging techniques rather than a single technique. Staphylomas has been classified in various ways. There used to be a Curtin's-Old classification. Then there is something called as a TMDU classification. There is a Tokyo Medical and Dental University classification. On OCT, you can see there is something called wide macular staphyloma, narrow macular staphyloma. Then there is a nasal and periphery. So there are various location wise you can classify the various staphylomas, and even the MRI gives a better clue to the location with the various angles if you take an MRI scan. So apart from that, the staphylomas, you can pick up the peripheral retinal degenerations also with this. You can see that there is a vitreoretinal traction shown by this is a vitreous, this is a traction of a peripheral retinal tear causing the lifting of the edges of the hole. and you can see the inverted OCT image shown as an arrowhead. So you can scan the peripheral holes and the degenerations on a multimodal imaging. This is a hole which has been scanned, which has been lasered, but still post laser also you can see the edges of the hole are lifted. Sometimes the presence of fluid also can be well noted. Here also this is a scanning of a peripheral retinal hole. This is a vitreous adhesions. The particular scan shows the opening of the hole and the adhesions causing a traction. Operculated hole, you can clearly make out the operculum with the ultra wide field imaging, which is an extreme periphery, which would have conventional imaging would have missed this, and multiple HSTs. I would say the ultra wide field fundus imaging, sometimes if you do meticulously do a imaging techniques and all, you can get away, especially with the comprehensive ophthalmologists, those who are not well versed with the indirect peripheral examinations. Lattice degeneration, you can see the clear cut lattice degeneration. There is a vitreous adhesion, there is a due to traction development of an hole here, and there is a fluid. So all these subtle changes which sometimes clinically you miss can be picked up on. Similarly, there is an RD with lattice. You can see that the lifting of the edges and the presence of SRF can be picked up. See, this is a patient who has undergone an encircling band. You can see the indentation here. In spite of it, over the buccal there is still the fluid is present, and because of the traction of the vitreous. So subtle changes which helps you to make anatomical changes, which helps you to pick up the decision making. Even the pneumoretinopexy, the amount of fluid which is present post gas injection, you can monitor that, the degree or the amount of fluid. And even the peripheral retinal degeneration, like this is a patient with white without pressure, schisis and RD, all three can be imaged at the. Even the cystoid changes shows typical sawtoothed schisis like separation, which is very well shown on a OCT than the clinical picture. This is a patient with a SUNIL degenerative schisis. This is a schisis showing this clear splitting of the retinal layers. Even the vitreous condensation, see, so very well demonstrated here, the addition of the vitreous in the mid-peripheral region. You can know exactly the PVD status, which is very critical in when you're planning a myopic vitrectomies. Sometimes a subtle changes like this, because of the vitreous traction, some patient has developed a lamellar hole shown by the arrow. So those things can be picked up, even the peripheral retinal tufts. This another thing is a wide field infrared reflectance in a patient with schisis. You can see the exact demarcation and the extent of the schisis can be made out. And here it is a very well demarcated, the schisis edges. So it's a very full useful technique. This is the outer layer hole, the extent of the SRF and the schitic fluid. Similarly, there's a tear which has been shown on an infrared reflectance image as an hyperfluorescence thing. So there will be, if somebody has got an associated peripapillary choroidal atrophy, they will be associated with the choroidal thinning. In a macular diffuse choroidal atrophy, the choroid is almost thinned out. In this patient, the choroidal thickness was around 12 micrometers. But with this thickness also, the patient had a well-maintained, best corrected visual acuity. Only the large choroidal vessels were seen in this patient. The patchy choroidal atrophy, in this area, this is the area of patchy choroidal atrophy. In this is outer retina and choroid has totally disappeared, and inner retina was sitting on the sclera. Myopic CNVM, which I don't want to go into the details, Dr. Sachin will be covering in his next talk. One should differentiate between a simple macular hemorrhage from a myopic bleed. So the simple macular hemorrhage doesn't require any treatment, which on follow-up has disappeared with the OCT being normal. This is the macular hemorrhage secondary to lacquer crack than a myopic CNVM. Even the lacquer cracks could be well delineated and well imaged with the imaging techniques. There are various changes, like sometimes you can see a multiple lacquer cracks. The choriocapillary disappearance can be seen in the area of lacquer cracks. The branching lacquer crack pattern, cracks may progress to patchy atrophy. There is another entity which has been described as myopic stretch lines, as you can see here. These are basically due to proliferation of the RP cells you tend to see adjacent to the choroidal vessels. The another thing which has been described is a linear or a leaf-like radiating towards the periphery lesions. These are called radial tracts. These can be identified on autofluorescence also. Then there is something entity which has been described as myopic macular pits. These are seen due to the traction in the area of CRA. This has to be differentiated from localized staphylomas. Peripheral avascular zones can be seen. Sometimes it can extend up to the staphylomatous edges, so it helps in wide field FFA helps in this. Then there is a macular vertex vein. It's quite an unusual thing which you do not see in regular patients. In an eye myopia, the prevalence of posterior staphyloma is quite high in these patients. Even the peripheral displacement of emissary posterior ciliary arteries, they tend to be seen in the posterior pole, but in myopes they tend to migrate towards the periphery. And the dilated and tortuous choroidal veins also can be seen, which is draining into the ampulla of a inferotemporal vertex veins. And sometimes there could be abrupt ending of the choroidal veins and the disappearance of choroidal veins at the staphylomatous edges. And you can see a shunt vessel from one vertex ampulla to the another vertex ampulla, right, running across the macula. Cilioretinal veins usually you do not tend to see in regular patients. We tend to see with CRVOs, but in myopic patients it can be seen without the thing. Another important thing is the ultraviolet field in this patient with a macular hole helps us to pick up a peripheral atrophic hole. Sometimes we could have missed this. Myopic traction maculopathy will be discussed further. Another thing is dome-shaped maculopathy, which Dr. Darius will be talking about this, so I will move on with these slides. So, a lot of optic disc changes also can be seen in myopia, which tends to mimic and cause visual field defects and can cause confusion with the glaucoma, especially intracortical cavitations associated with or without cavities. There is a presence of scleral ridge. These are some of the changes, disc and peripapillary changes can be seen, multiple disc pits, the conus pits in the pathological myopia. And then there is an enlargement of subarachnoid space in myopes. The relevance of this is sometimes the CSF pressure itself can bring about the optic nerve changes. So they tend to have an optic nerve progression in myopia in spite of a normal IOP. So we need to conclude that. So this peripheral visual imaging in myopes helps in confirmation of diagnosis, helps in treatment. Any comparative ophthalmologist can adapt this technique, those who are not well versed with indirect ophthalmoscopy also, and telemedicine initiatives. The telemedicine of myopic patients, you tend to pick up many lesions, which helps in the treatment of these lesions. Thank you, Vandanal.
Thank you, Sunil. That was a wonderful talk. Any points to add or discussion, questions?
Yeah, we'll take questions after 2-3 talks. Okay. You go ahead, if you have got anything.
No, it's a wonderful tool, not only for diagnosing the things, but it can be a tool for screening the patients in the OPD. Non-retina surgeons also can pick up a lot of lesions. So in that way, it will be very useful.
Yeah,
only the
it's
cost
a very valid
factor.
point, because not many ophthalmologists will be trained in peripheral retinal examination. So definitely it add value to your OPD practice.